All right, well, welcome back from lunch. My name is David Chang, and we're going to be running a cataract video complication symposium for the next 90 minutes. We call it You Make the Call, because you and the audience get to weigh in on what you would do. There'll be some audience questions. There's a QR code which you can scan. We're not sure how the Wi-Fi is working. We may have you raise hands if we otherwise need to. So I have no real relevant financial disclosures. We have an international panel, Deepak Magur, Arup Chakrabarti, Bonnie Henderson, Charles McGee, and Sunpek Chi for the first two cases. Now, my first case is a patient with zonulopathy referred to me with a right cataract. So we're going to refer this patient to David Chang, and she's 64 with a big myopic shift. She's 2400. There's some history of being hit with kind of a Nerf that's one of these little rubber football darts, and she also does rub her eye, and so that's the case. Now, there is some movement. This is at the operating table, and it's just sort of showing that there's a little bit of jiggling with this eye that we can see even there. I don't know if we can lower the lights on the stage at all, or whether that's realistic. Now, so let me just ask the panel, I'm not going to ask everybody, but how many in the panel would actually do a manual extra cap? Just raise your hand, panel. So you got pseudophacodenesis, 64-year-old, not a particularly dense lens. That means everybody's going to phaco on the panel. All right. So the next question, capsulotomy method. And I think I'm just going to, again, say how many people in the panel would do a femtocapsulotomy? So one, okay. And everyone else would do a manual, all right. Deepak? Yeah, there's a little switch on the microphone, so you can just grab the hand mics. Charles, you want to get the other mic over so almost everyone has one, and just leave them on.
Yeah. So I don't have access to femto. That's the reason for choosing a manual.
Okay, all right. And so everyone else is going to do a manual. All right, so let's go ahead, and here's where I start. Now, this is where you can really tell what your zonules are like. And you see there's a lot of movement to this lens. It's really shaking quite a lot. So I'm going to aim small. There we can, the big pupil, but we can kind of see the equator of the lens. And that's partly because the pupil's large and partly because I can decenter the lens. So I'm going to aim a little bit smaller here. And so we're going to try audience question 1.1 now. And let's see what that first question is. All right? So the question is, what are you going to do with this phacodenesis? All right? So here are the choices. You could start careful phaco, a CTR or capsule retractors in phaco, or convert to an extra cap. So please vote now. Why don't we see, I'm going to have you raise your hands. Raise your hands if you're just going to start with phaco. How many people would put in a CTR? How many people would do capsule retractors? And then how many people would do an extra cap? All right. So it looks like the number one answer is a CTR with phaco. Bonnie, what do you think?
Yeah, I agree. I think that it's too loose to just put in a CTR, so I think you need some additional support, so retractor seems reasonable.
Okay. So I think the number one answer is CTR with phaco. Arup, what do you think about, would you do a CTR next or capsule retractors?
I think I'll go for iris retractors or the rexis retractors, stabilize the bag, and then go for phaco. All right. Because insertion of CTR at this stage may be quite traumatic to the zonules.
Okay. How many of the panel would just go with choice number one, which is just to go right into phaco? All right. How many people in the panel would do choice number two? And choice number three is capsule retractors? Okay, so that seems to be a lot of people. All right, so here are These are microsurgical technologies. This is what are available globally, but certainly very popular in the United States. Come with a set of 4. Any tips on using capsule retractors, Deepak? Your thoughts?
Yeah, the incisions have to be very short. You don't want a very long incisions. It's easier to navigate. Preferable to have a little bit more posterior incisions. And sometime for easier insertion, hooking to the capsule, I would prefer a small amount of OVD just to tent up the capsule a bit so that the hooking the capsule to the, under the capsule would be easier.
All right, sounds good. I think the other tip that I'm trying to do here is I want to support it, but I don't want to make it too tight, because when you put the phaco tip in and you got that infusion, it's going to push the lens back, and that will sometimes tighten them a little further. Now, one of the benefits here is I'm getting zonular countertraction, where my normal zonules are not there so much, and I'm deciding not to rotate this necessarily much, because it's not that dense if I can split it in half. And notice how, because I didn't rotate the lens, I have to reach across and kind of cross chop. And I'm just sort of a little concerned that got a little tight, so now I loosen it. Now I can rotate it a little bit after I've chopped it in half, and we'll go along. Charles, any tips on phaco with such zonulopathy? Just leave your mics on, panel, because you're going to be on the spot here. Yeah.
I agree, number one is not to rotate very much as possible, to do a reasonable hydrodissection. As was suggested earlier, I like to use a little bit of visco to tent up the capsule away before I start the phaco. I agree, you don't want too much tension. You can tear the bag by suddenly letting in too much fluid.
I'm going to interrupt now. Watch the top of the screen. Watch right at the upper edge there. Keep watching. Go ahead, Charles.
And I'd probably do a groove and then chop.
Okay. All right. So I'm kind of pausing here. So it's a little hard, obviously, in the monitor, but let's go back a little bit. And if you look right at the upper edge, there's going to be a moment where, so the nice thing about CHOP, of course, is we're able to stabilize the lens with the phaco tip. So we're not, I'm going to stop here. All right. Oh, I guess this is where I was rotating it. Anyway, there's kind of some marks on my screen right there. Okay, so I'm having to go under the anterior capsule rim. I'm chopping in there. Look at the top, kind of right there. Did you see that? Did anybody see that?
I think the zonular dialysis is trying to extend.
Yes, Namrata, that's right. There's a zonular dialysis there. So these are the MST retractors. So I think I'm sort of stopping here because I've kind of got the nucleus out, and then I still have to get the epinucleus and the cortex. And I guess any thoughts here in terms of strategy for epinucleus cortex with zonulopathy? Arup?
So at this stage, I think I would adopt a visco shield strategy, where I'd use a copious amount of visco to stabilize the capsular fornix, and then levitate the nucleus at a little more anterior plane and go ahead with safe phaco chopping. And as phaco parameter settings should be on the lower side.
All right.
So you wouldn't put a CTR at this stage?
Well, so I think that's one of the questions. Now see here, I kind of froze frame here. Do you see how this was that spot where it just happened so fast in real time, but there is a little bit of a zonular dialysis there. So I got that epinucleus. So now how many on the panel would put in a CTR at this point? Wow, okay. Because normally, what do? We try to wait till the epinucleus and the cortex is out. So I'm kind of going along with that. Give me some ideas on how to put a CTR in with this much stuff there. Deepak? Yeah.
Yeah, again, the real challenge is to create a space under the capsule. So one trick would be to just use a cohesive OVD, push a little bit so that you create some space there, and then we can navigate the CTR in the space. And using an injector, which you did it here, I think that would be the safest way to maneuver the ring into the capsular fornices.
So that's what I was doing. I was injecting a dispersive and trying to push the epinucleus down so I could get the CTR in front of the epinuclear shell. Bonnie, were you going to
The other
add?
thing you could do is, because it's one area, you could put in a segment, an OMED segment, and that will, you can actually just hold it there with a capsule or an iris hook, so that you don't have to suture it in place, and that will give you that sectoral protection there.
That's another excellent suggestion. And a little hard because I couldn't see too well at that point, but you can again push everything back. So I like that idea. And so with the CTR now, what you don't see, we've sort of closed off that peripheral dialysis a little bit. And you can see that this is the epinucleus coming out. Just then, I put in a little viscoelastic dispersive to push the capsule back, and it looks like we've got most things out. All right. Any more comments from the panel on the phaco on this case? All right.
I would prefer the fragments to be much more smaller. So I'd like to make more fragments so that they don't tug on the capsular margin when you're trying to emulsify them. So instead of maybe making 6, I would make 8 in this special situation.
You're talking about the nucleus disassembly, because this is
management.
at the epinucleus. So that's a good point. Yep. All right. So that's, again, putting the CTR in. All right. So we're here at the end. So now we've got a question for the audience. This is 1.2, and it's about what IOL fixation, not alone just what IOL, but what fixation. You saw we got a dialysis, we had phacodenesis. So if we can get to question 1.2 anytime, Karen. The choice would be, do you put in a regular CTR or a sutured CTR? Okay, we'll show the choices. Do you do a 3-piece IOL in the sulcus or something else? So if you can get that QR code, you can vote anonymously. Otherwise, you're going to have to raise your hand. So how many people would do the red choice? That you got a bag, you got a CTR, let's put the lens in. How many people would suture a CTR, which means you got to put another element in there, either like a CTR or a capsule tension segment? Okay. How many would put a 3-piece in the sulcus? And how many would do something else? All right. Okay, so several people would do the sulcus. Panel, how many people in the panel would do number 1, the red? The red choice is bag plus CTR. All right. And then how many people would do bag plus a sutured CTR, which would be the segment? So in fact, what would you put in? Would a Malyugin CTR or just segment?
No, I would put in 2 CTS.
CT segments,
Yeah.
okay, got it. How many would do a 3-piece in the sulcus? Okay, so we got 3 votes. And something else? Iris claw, anything dramatic? Use the mic. A rope?
3-piece IOL in the sulcus with a optic capture.
Great, okay. And Bonnie and Deepak, you agree? All right, okay. All right, so I'm going to do what the majority does, and this is 3-piece in the sulcus. Deepak, why don't you walk us through this technique of 3-piece in the sulcus?
I think it's a great way to stabilize the bag. The principle which I learned from you would be like the optic actually it traps the bag, and maybe especially in cases where you have a generalized zonulopathy, not specifically in this case, it's actually the bag which the bag is held by the optic of the lens. The haptics are placed in the sulcus, and the optic is pushed back, and the haptic and the optic are in 2 different planes. And our assumption is that it definitely helps in better long-term centration and stabilization of the lens.
All right, excellent. So I've kind of got it here, and it's really hard to tell because there's this arcus on the left-hand side, but where's the pupil? On the left-hand side, does anyone see the iris? it's hard to see from these monitors, but I'm having a little trouble seeing the iris, and I'm not sure we're even in the sulcus. So, you know, it's an asymmetric pupil. So here I'm just sort of making sure, you know, this one haptic didn't end up in the angle. This pupil dilated so widely. You saw that when I did that capsulotomy. There for sure I've tucked it underneath. All right. And when you do this technique, it is kind of nice to have the haptics in the 3 o'clock, 9 o'clock axis, because that's where most of the saccades are in the horizontal axis, and that gives you that extra contact between the ciliary body and the haptics. So that's looking for sure there, but the pupil's still kind of dilated there. And maybe so I'm just trying to massage it and sort of make sure I can see the iris. All right. Anything else you would do to get this pupil look? What's that stuff there? Okay, Bonnie.
The dreaded vitreous right there.
Yeah, all right. So I'm not, maybe that's just cortex. Maybe, not so good. All right. Yeah, it looks like vitreous. God, we were so close. We had the lens in. We did everything so well. And I hate it when this happens. All right, so we're going to ask the audience now, 1.3, and that's, do we need to do a vitrectomy? Okay, so we're behind schedule. This took a lot longer. Do we, question 1.3, Karen. So do we sweep the vitreous from the incision? Do we do a Weck-cell? You go to the questions now, and maybe use a Weck and some scissors. Can you go to the questions, please? Do we do an anterior vitrectomy? If so, through the limbus or the pars plana? Karen, we need to see the questions. All right, so please vote now if you can, audience. And how many on the panel? So one of the questions is, can we just sweep this from the incision or do a Weck-cell? So how many on the panel think we can get away with that? That was a tough panel. So how many people in the audience think we should just sweep? Nobody. All right, so that's, okay. So that means we're going to be doing a vitrectomy. So in the panel, how many would just go through the limbus? Raise your hands on the panel. And how many would go through the pars plana? So it's 4-2. All right. Audience, how many people would go through the limbus? Yeah, a lot. And how many through the pars plana? So much fewer. Okay. All right. And just to remind you, the panel, we can go back to the video on both sides. The panel has not seen these cases, so they are on the spot. Just in case they get upset, that's why I put my podium really far away from where they're sitting. Okay, so I'm just going to try to get away. It seems like it's right at the edge, and I'm just going to use my vitrector, small gauge vitrector, almost like a spatula, knowing that wherever I do get this impinged, I can cut. Panel, should I have done triamcinolone for this? I'm kind of doing it now to be sure, but I just figured I could see it before, and I'm sweeping, so I am using the triamcinolone there. Certainly you could go through the pars plana because obviously this is coming through a zonular dialysis and it could very well get caught there. All right, so I'm kind of stroking things here, and now I'm, you know, we did a paper on our Irvin study that even if you don't normally use intracameral antibiotics, if you have to do a vitrectomy or there's a breach in the capsule or zonular dialysis, the rate of endophthalmitis goes up quite a bit. It's like 7-fold, and so you should definitely do it then. All right, so this patient ended up 2025, and we aimed for myopia to balance her, did okay, and went very well. All right.
David, can I just make a comment before
Please.
you go to the... Yeah, no, this is in connection with the technique of IOL implantation.
Okay.
So what do you think about just placing the lens initially in the anterior chamber and then using a Lester hook or a Sinskey hook and tuck the haptic just under the iris so that you are sure that it is going into the sulcus and not entering the bag. So I have been doing it for quite some time, and I've been pretty happy with the outcome.
Yeah, I think that's a reasonable point, because this begs the question, when did I create the vitreous prolapse? And maybe it was with either trying to rotate it in or trying to capture the optic. All right, that's a good point. All right, so I'm going to move on to our next case. Any other final comments from the panel? So it's a case of zonulopathy, a lot of things we discussed there. All right, so we have all seen posterior subcapsular cataracts. This is like the most posterior cataract I've ever seen. So this is a case where she's had myopic LASIK, but she's gotten consecutive myopia, so all she does is wear distance glasses. She reads without glasses. On the questionnaire, though, she wants to see without glasses in the distance, doesn't mind glasses for near, and this is the 20/60i with the cataract. Charles, what do you make of that cornea? You just gave that beautiful lecture on keratoconus and the topography. The topography.
Well, it doesn't look like keratoconus, but it does look like a very decentered ablation.
Okay.
How long before was the LASIK?
Oh, it was many years ago. She's 70 now, so she probably had this in her 40s.
And do we know what her myopia was at that time?
Not really. No, we don't have records.
Well, the interesting thing is that she doesn't really have an awful lot of astigmatism, considering how decentered that is.
Yeah, so on the eye trace, it's actually measuring almost 4 diopters at axis 75. Yeah, so it's measuring the refractive cylinder. Let me show you the other eye just there. So the better eye on the left has 2.61 with the rule, but she's got 4 diopters at axis 75. This is using the ray tracing over the 3mm pupil. So, you know, she is very meticulous about her vision. She's absolutely not interested in a rigid contact lens, has never worn a contact, doesn't know why she would ever need to, wants to see well in the distance. So I need to ask the panel, let's ask the audience first. Question 2.1, Karen. So I want to know what lens you would put in this woman who's very demanding in terms of visually demanding, probably her personality. Would you just do a monofocal? Let's show the choices, please. So you could do a monofocal and maybe a scleral lens. You can do a monofocal toric, an EDOF, or something else. So let's please vote now. All right. How many in the audience would do a monofocal? How about a monofocal toric in the audience? How many in the audience would do an EDOF? All right, great. So, panel, yeah.
I think one of the things we need to know is what was her best corrected vision, say, 5 years ago? Because if she's got orthogonal astigmatism, which is correctable by spectacles, then a toric makes a lot of sense. But if she's always been down at 20/30, 20/60.
So we've discussed that, you know, she has irregular corneas and that her best vision would be with some type of rigid lens. But she says, no, I just want to see like I used to. And she will just not consider that, you know.
Then she's got a problem. I'd give her to another surgeon.
Okay. Sunpek, what lens would you give her?
If the astigmatism is not regular, I would just put a monofocal because I don't think a toric can really do the job.
Really?
Yeah.
Okay. Because she's going to be wearing, otherwise, her goal is distance without glasses, though. Yeah. Deepak?
Yeah, if the astigmatism is regular, I think you mentioned it's a regular astigmatism. Maybe I could consider monofocal toric, but definitely nothing EDOF or anything else multifocal.
Yeah, I mean, there's no question she'd see better. She's got irregular astigmatism. She'd see better with a rigid contact. This is her personality. She would not want to be bothered with that. She's busy. She has, you know, a lot going on. Bonnie, in the United States, we have the light adjustable lens. We use that a lot. the problem here is she needs 4 diopters, and the light adjustable lens, you squeeze maybe 3 out, but is that still a consideration to take away 3 of it?
Yeah, I mean, I think that that would actually be the best option because her corneas the astigmatism is in her cornea, obviously. And so if that's what she's wearing right now, once you take that lens out, I definitely be worried about the residual astigmatism. And it's going to be somewhat unpredictable. So I think this is really a good case for a light adjustable lens. Even with the residual -1 of SIL, that would be acceptable.
So, David, you didn't put the EDOF toric. That's also a possibility.
Yes. Would you do an EDOF?
Toric.
Yep. Okay. Diffractive or refractive EDOF?
Refractive.
Refractive. Okay. All right. So we have everything from monofocal toric to referring her to someone else. And no, we really discussed this. She needs a T7. And my feeling is she's going to either wear glasses, and the less astigmatism she has, the better. Okay? So a lot of discussion, a lot of hand-holding. And, I kept going after the last piece, and it kept moving away from the phaco tip. And I said, this doesn't seem right. So then I got the cortex out, and I tried to aspirate it, and it kept moving away, and this doesn't seem right. What's going on? This is behind the posterior capsule. Yeah. Okay, and it's right in the middle. And I told you a little bit about her demanding personality. And so this is why I say it's a really posterior capsular cataract. And I'm wondering if she'll accept the notion that maybe it was there to begin with, and it wasn't due to me. But all right, so just so this is focused now on the rexus, so you can clearly see it's in Berger's space. I don't see any vitreous. And so let's go to panel. What would you do? Where did it come from, first of all? Arup? Where did those pieces come from?
You are referring to the chunk of nucleus that we are able to see here? Yeah. So I think, I'm not sure whether it is a rexis extension that has happened nasally, but, it is in the retropupillaris, the Berger space, and at some point the PC gave way, and then this chunk of nucleus, the lens matter found its way behind. I think that is what, according to the sequence of events.
All right. So I'm just thinking, Charles is the happiest because he's referred this patient to someone else already, so he's clear. Any thoughts on what to do?
Just a question. Is the posterior capsule is intact still?
Yeah, I think so.
Yeah, so
because I just cleaned up all the cortex,
Yeah.
and I just was watching these pieces, and they just didn't come, and I thought I could ask
Yeah,
them.
I have had a couple of cases. There's a possibility of the lens fiber, lens matter, lens debris to go transzonular in cases of generalized zonulopathy where the barrier is compromised a bit. So I feel that would be the mechanism in this case, but again, that's because you have said it is a really deep posterior subcapsular cataract. I'm not sure whether it was really behind it before that, but my assumption is intraoperatively it would have migrated there.
I'm just going to show you a little bit more. So, here I'm just thinking, what's going on? And right there, this is going to be tough to see. There's a notch in the anterior capsule.
Case was right.
Yeah, and then it's going to be harder here, but right over here, there's my mouse, there's a round edge here. So this is my chopper. My chopper went through the anterior capsular rim, and the tip of the chopper made a little curved notch. So that's how it got back there. So mystery solved. It's my fault. All right, so I went through the back.
Are those nuclear fragments or epinuclear fragments?
Yeah, it's a really good question, and those are nuclear because
That's too bad.
Unfortunately, I wish they were epinuclear. Because would you leave them if they were epinuclear?
I would.
Yeah.
Yeah, I would.
Yeah. All right. So okay. So this is how they got back there. There's a kind of a good view right there of that little hole in the posterior capsule where my chopper went through. Okay, so we got a T7 that needs to go in here, and we got these. So let's ask the audience question 2.2, Karen. And So should we implant the lens, go to the options, and then leave the fragments alone? Should we retrieve the fragments through a pars plana vitrectomy? Should we try to move them out of the way with viscoelastic or do something else? So go ahead and vote. So how many people would say, just leave them, you know, you can always let maybe they'll absorb. How many people would just do the red option and just put the lens in? It's a T7, okay? So a bunch of the audience would. How many people would go after them with the pars plana vitrectomy? So it's a lot more people. How many people would try to push them away with viscoelastic? It's like couching the fragments. Not so many. All right. And how many people will do other? Okay. All right. So I'm going to, let's see. I'm going to try to move them. This is viscoelastic, but there's a capsule in between. But I'm just wondering if I could sort of massage them, you know, and work them a little bit peripherally. Because knowing her as I do, I can get the lens in, and she's not going to be happy that she can't see. And she's going to say, you know, it's blurry, and well, they didn't really go anywhere. All right, so panel, it's up to you now. All right. Help me out, Bonnie.
I still think you could put a toric in. Your anterior capsule rhexis is still pretty good, and I think
Yep.
if you center it right, it's fine, but you do have to take those pieces out. So I do think the pars plana is probably ideal.
So you would put the lens in first and then go through the pars plana?
I would actually do the pars plana first, and then hopefully it will stay fairly strong enough to actually put in the toric lens.
All right.
Yeah, I think the lens fragment removal is mandatory. Maybe I would prefer to do it before putting the lens inside. And the toric lens, it depends on the axis. If I'm not mistaken, it was 75 degrees, if I'm wrong.
Yep.
And you're
So it's
sitting
with the roll.
You're sitting temporarily. Yeah. It is still, we have an option, but yeah, remove the fragment and then assess the situation and maybe consider a toric lens still.
Okay. Sunpak, you're creative. Give it any.
Yeah, I would go through the pars plana to clear those fragments first, but my concern would be, you know, it might drop. When you're going through the back, it may drop.
Yeah, exactly.
Yeah. But I will also try to do a optic capture. Yeah, with that axis, it should be fine.
So optic capture with a toric. So reverse optic capture? Oh, okay. Got it. Arup?
Yeah, I mean, I would agree with everybody that, you know, we have to go to the pars plana to remove the nucleus chunk. And then I will assess the residual, zonulus, the status, how much of, bag is stable, and then still go for the toric, for EDOF lens, EDOF toric.
All right. So Charles, the doctor you referred her to is calling you now and saying, what should I do?
I would be saying, first of all, call your Medical Protection Society for your indemnity. Then I would probably do a pars plana removal. And I'd probably be tempted, because the rhexis is good, I'd probably be tempted to put in a tension ring. I'm worried about that little gap in the periphery. So we want the capsule a bit tighter, so probably a tension ring and then a toric.
All right. So, and Namrata?
I agree with Dr. Arup. I would also go through pars plana, remove those, and then put a toric lens.
Okay. So all of you would do the vitrectomy or the first, and then the lens. No one would put the lens in first? Okay. Yeah, I know. All right. So, so I'm going to do other. And so it's like right there. So I am going to do incising the posterior capsule, and I'm going to try to do a posterior capsulorhexis. Now, how do you do that? Well, this is a 30-gauge needle, and you drag, and remember it's really thin, and these forceps they're Barry Seibel's tip from the Microsurgical Technologies set, are really nice for this because you can turn them, and you don't go through the phaco incision, which would shallow the chamber, and you can rotate it and come through a different port. So this part is my left-hand port, but see how I can rotate it so the jaws can grab that really thin edge. And you basically use the Brian Little capsule rexus tear out rescue maneuver, and I'm about to connect it there. And now we're through. So we've got a posterior capsulorhexis. Let's ask the audience, what do we do now? So question actually we're going to go to 2.4. So let's do 2.4, Karen. And so are you going to let's do 2.4. So are you going to visco-levitate the fragments, or would you just grasp them with some forceps? Would you aspirate them, or would you leave them alone? All right, so how many in the audience would visco-levitate them and try to milk them up front? Okay, all right. How many people would go after them with some kind of forceps and just pluck them? Nobody, okay. How many people would try to aspirate these, like with an INA? All right, and how many people would leave them alone? So just a few people, all right. Okay, panel, we'll start on the other end. Namrata?
I think I'll like to aspirate them with a vitrector using the IA cut mode.
Okay, now she's got an intact hyaloid face so far. Charles?
I think you're kind of between the devil and the deep blue sea, but you've already phoned your defense attorney, so that's good. I would probably visco elevate if I thought the face was intact. I wouldn't put forceps in there, so chance you'll grab some vitreous.
Okay.
I think, David, it was quite an innovative thinking. So what I would do is almost the same. Use dispersive OVD, elevate the nucleus, and use a lot of viscous, the plug of the OVD to keep the posterior capsule open. And then maybe I just go in with my phaco handpiece with very low settings, and it comes out, it can be taken out without much problem. Take out the nuclear bits.
So I'm doing what you're suggesting. Now, part of it is they're moving away from me, and that one at the top of the screen is kind of going under the anterior capsule into the fornix. So I kind of have to stop injecting, and now I'm trying to steer them into the anterior chamber rather than, see, that one's under the anterior capsule. So that was in the bag, and I'm trying to get it back out now. And, I wish someone made a forceps for this exact situation, but I'm just basically trying to not disrupt the anterior hyaloid and see if I can steer them up here. Anyone want to do a IOL scaffold?
David, actually, I would have put in the viscoelastic from that rib area and then pushed it up from below.
Yeah. And would you have repositioned the microscope or just sort of come across?
Yeah, just come across.
Yeah. So, here, my main goal now is just to get these into the anterior chamber, keep the bag pressurized so that the hyaloid doesn't come, and then try to steer these as close as I can. Phaco or INA or burp them out, or let's see, Deepak?
I would prefer to burp them out because they're small and they can be negotiated through the 2.8 incision which you're done. So I think my preferred would be the burp them out.
All right. So we're going to take a timeout from this case to put in the lens now, because I think my first thing is, if I can get the lens here, I can put a door in front of that posterior capsular opening. So whatever method I want to do, I'm going to, do this. This is a kind of an IOL scaffold, but it's basically the IOL in the bag. So you can see that I've lined it up on that 75 axis. And so here I do think, Bonnie, would you burp them or aspirate? This is, it's kind of coming out.
Yeah, so and since you have the IOL there now, I think if you can burp them out with viscoelastic, great, but I would feel more comfortable aspirating if I needed to at this point.
All right. Yeah, so fortunately they came out, and there's one more little piece here. All right, so, and I think, any thoughts in terms of, so at this point, there's no vitreous. Do we put in triamcinolone to be sure, or should we just assume it's okay? Charles?
I think with that amount of manipulation, it would be safest to put in triamcinolone.
Yeah.
Your attorney will prefer it afterwards.
So here is, we're going to peek again at that trouble spot. You get a little bit better red reflex. All right, so right here is that curved puncture in the posterior capsule with the tip of the chopper, and right over here is that notch. So that's where they came from. So I elected to just put in Myocol. The pupil isn't peaked, the PCCC was okay, and I think we're okay. So we got that through. So I did get that T7 in, and here's the answer. So our best corrected is 20/30 because of the irregular cornea, but it's a manageable refractive error, and she did then, based on that, go ahead with the T6 in the other eye, and that eye had the better cornea, so she had better vision there, and she has no idea what an adventure we went through to get that. So at this point, I'm going to thank our first panel, and then we'll bring our second panel up. So they did a great job, so give them a hand. Namrata, you please stay. You're going to be in the second panel. And my next panel, we have Doug Koch, Vladimir Pfeiffer, and Fasako Areta, and Tetsuro Oshika. All right. So those seats are very hot. I'm going to show a case of a posterior polar cataract, okay? Now, this woman is 58. She wears contact lenses in one eye, so she's a monovision. And her near eye has the posterior polar cataract. She's only 58. She really wants to see at all distances, hates glasses, and she has a half diopter of cylinder. So panel, what choice would you steer her toward? She really wants help from you to decide what IOL. Tetsuro, I'm going to ask you first.
No, I'm sorry, I couldn't hear your question.
So she's doing monovision by wearing a contact lens in the right eye. She's got a posterior polar cataract on the left eye. The right eye is okay, and she wants to see without glasses. So your choice of your recommendation for IOL on the left eye.
You mean the left eye had posterior polar cataract and posterior polar on the left eye. And she wants to get rid of the glasses. She prefers monovision. Yeah, monovision is going to be fine. Or maybe if she agrees, we can put the multifocal lenses on the left eye.
Okay, all right. How many in the panel would put in a multifocal? So 2, okay. If you're not doing a multifocal, what would you do? Fas?
So you said she's happy with her monovision?
Kind of, yeah.
So I think that's a good option. So for the
Okay.
left eye, I would leave it maybe a -1.5. She does have against the rule astigmatism, so you could consider a toric, but I feel the clarity with the monovision, if patients can tolerate it, is excellent.
Okay, great. Doug?
Yeah, I agree. And also, that's a funny-looking topography, so I'm not sure that's a great topography for a multifocal. I definitely would lean toward a monofocal. Normally, I use monofocal plus in a lot of patients, like the iHance or the Aspire, but in this case, I'd probably use a straight monofocal because of the cornea.
All right. Namrata?
So I also would put a monofocal because she's already using a monovision.
All right. So we discussed this, and I said, you know, one of the misleading things is most of your life you've had some accommodation, right? Your early 50s and so forth, and a monofocal isn't going to give you the same range that you've had. You're going to need to be a lot more myopic to do that. And she does have a little cataract in the right eye. And so after weighing all these choices, we've come up with the Panoptix for the left eye, okay? So we go into surgery, and you can see the posterior polar cataract, and I've paused here, and that's because there's this line right from, right over here, there's this line, and I'm going, oh gosh, is that a fold in the capsule, or is that a rent? So, all right, question 3.1 for the audience now. So there's a possible rent here, and what's your next step? So let's show the choices, Karen. You could do maybe INA on the other side, like most of that stuff is proximal. Would you try to sweep from the side port with a spatula? Would you remove the INA after putting in OVD first, or would you ask ChatGPT? All right, so please vote now. So we think there's a rent. How many would just continue INA? How many would use the side port spatula to see if there's vitreous there, to test for vitreous? Great. How many people would come out now at this point? Let's get out of there, put some viscoelastic in test. And how many people would ask ChatGPT? All right. So the next best thing, I didn't have that in the operating room. In San Francisco, we have a very famous policeman named Inspector Harry Callahan. So I asked him what to do.
I know what you're thinking, Dr. Chang. Is there vitreous? Well, you have to ask yourself one question. Do you feel lucky? Well, do you?
Okay, well, do I feel lucky? So panel.
Yes, I would go with AE, irrigation aspiration, but
Yeah.
I would do the only with irrigate with viscoelastic. I wouldn't put any BSS anymore in the eye. So dry irrigation aspiration, if possible. And also using some triamcinolone to see where the vitreous is if the vitreous is there or not.
All right. So Vladimir, what I'm finding here is I did sweep, and it looks like there's something stringing there, and it could be cortex, but I'm not. It also looks like vitreous. So this is step one. Foss, explain what I'm doing there. I'm putting in viscoelastic.
Yes, putting viscoelastic, and like you said, there is likely a tear sort of next to the posterior capsular plaque. So I'm sure it's one of the 25% of the cases of posterior polar where there was a break.
All right. So in response to Clint Eastwood, this is not my lucky day. I've got a lot of vitreous there. So audience question 3.2. Now, what are you going to do with all this vitreous prolapse? Are you going to do go ahead with the choices. Anterior vitrectomy, are you going to do it through the limbus or the pars plana? Would you just stop here and we can refer the patient or something else? So go ahead and vote. So how many people would do the red choice, a limbal anterior vitrectomy? And how many people are comfortable going through the pars plana? Okay, about half. How many people would stop? I mean, is that an okay option? We got a lot of material here, and there's a lot of vitreous. Okay, so more would do a limbal, but close second pars plana. How many people on the panel would go through the limbus? Okay, 3. All right, and then the other 2, would you go through the pars plana? Yep. Okay, Doug. Take us through your reasoning there.
Well, you've got a large rent there, and it's going to be hard to get all the vitreous through that rent, I think, is from an anterior approach. It's not unreasonable, but I think you have a better shot at it going through the pars and pulling things down, and so that's probably my choice. That's not a strong preference.
How? Tetsuro, you would go through the limbus?
Yeah, I go to limbus, but I think because if you remove a lot of viscerous body, from the cavity, you have a more increased chance of the nickel drop into the displacement in the vitreous. So I prefer not to remove the body of the vitreous.
All right, all right. And so, you know, it's tough to see with all that epinucleus and stuff there. So again, I don't feel strongly about it, but I just felt, let me just sort of, there's so much here, let me just get that out first. And then if it keeps getting caught, I'll have to go through the pars plana. My main goal here is don't cut the anterior capsule, which is my, you know, lifeline to getting whatever lens in. And these small gauge retractors, but you know, you can see I'm doing a biaxial approach. And now that it looks like it's been cleaned up, I'm going to go ahead and just start. We've got this epinucleus. Now, of course, with a posterior polar, I didn't hydrodissect. So this thing is really adherent. And, you know, I can't rotate it. Plus, I got a big rent there. So, and now it looks like I've got some more triamcinolone stained vitreous there.
Viscodissecting that would have been helpful, David.
Yeah.
You know, to get the epinucleus, you can really free it up and not struggle quite as much.
Exactly. So here, you know, to Doug's point, you know, there's still, I didn't get it all. So I went back in, and then now I'm going to go ahead and, but it, you know, again, this is the problem without the hydrodissection is you're not really mobilizing the epinucleus. Any other thoughts on getting this out now? So there's the viscoelastic. You know, let's go back again. So now I'm starting to think maybe I should have gone through the pars plana because am I just pulling up more through that rent? If it's a dialysis for sure, it's not going to fall back. You know, that's almost like a trap door. And I think with the difficulty with the epinucleus, I just thought I committed to the limbus. But now it's starting to clear up a little bit more. You see a little bit more of that staining going away. Vladimir, any pearls on vitrectomy in this setting?
Yes, from the beginning, I wouldn't hydrate. I wouldn't put any BSS into the eye. I would just irrigate with viscoelastic all the time and do the aspiration, dry aspiration. And also I would do the dry vitrectomy. Just irrigate with the viscoelastic, pushing vitreous backwards, take the dispersive viscoelastic, and try not to hydrate the rest of the vitreous, because if I hydrate the vitreous, it would come forward all the time.
Got it. Okay. Now, I'm finally going to get to the point of the INA. And Namrata, any thoughts on the type of INA going after that epinucleus?
I think I would, like you are using in this, do irrigation aspiration with the vitrectomy probe itself, using it in the IA mode, and then think of putting the IOL after everything gets cleared, and of course removing the vitreous.
Yeah. So I went back a little bit, and this is again with the vitrector. And now I think it's finally clear. I have all that residual cortex temporally. So I am going with the biaxial INA. One of the advantages of this is I can dissociate the irrigation and the aspiration. So the irrigation is anterior to the iris, and the aspiration is underneath the post-anterior capsular rim. Because with a coaxial, I have to tip that down, and that's going to point all the infusion through the rent. And so that's one benefit in addition to the better access to the subincisional cortex. Okay, this has been I've fast forwarded till later that afternoon, and now I'm using Namrata's suggestion of using the vitreous cutter as a aspirating instrument. So I'm going I aspirate cut just by switching the settings and using that. And this is the vitrector now. And again, the one thing you got to be careful is don't cut that anterior capsule. All right. And, well, this is pretty large. This is the size of Greenland. There's a piece of epinucleus there. All right. Let's go to question 3.3 now. Audience, what do I do with this giant thing of epinucleus? I got this open posterior capsule. Let's show the options. Karen, are you going to aspirate it with a vitrector? Are you going to elevate it and then use INA, or put the IOL under it and then do INA or something else? So please vote now. So how many would aspirate this with the vitrector? I mean, the vitrector is right there, and we're ready in case there's any vitreous presenting. How many people would just use the regular INA after maybe visco elevating it a little bit? Okay. And so the third choice is the IOL scaffold. Okay, well, that's kind of almost the winner so far. All right. Anybody in the panel, what should I do with this? And the audience is pretty much evenly split with those three. We can switch to both screens back. Okay. Tetsuro, you got the mic?
Combine 2 and 3. Combine the visco elevation and the IOL scaffold.
Okay. All right.
Yeah, if you don't put the IOL in, it's probably going to fall back because now we have a pretty large posterior capsular tear. So I think it would be nice to put the IOL in, and then you can use your anterior vitrector. And I don't see any advantage of using your bimanual IA because your vitrector can act the same way, pretty much. And so I would use the bimanual vitrector to eat the piece once the posterior capsule is tamponaded with your IOL.
All right. Anyone else?
The challenge of putting an IOL in here is what you're going to decide to use for the IOL. And I have this funny feeling you're going to put a panoptics in and do an anterior optic capture. And so if you're going to do that, you're putting your three-piece in the sulcus initially, and it's a little edgy to do because of the size of the posterior capsular opening with those haptics. And then if I did that, I would go ahead with regular INA because it's much more efficient removing it with an IOA than it is with a vitrector.
Yeah. All right.
So I think I would chase this first and then take a call on IOL, because if you're planning to put a panoptics, then you really need to know where you're going to put it. So if you just put it beforehand, and if it is there in the sulcus or if it is sitting on the iris, then I think it's always best to take a call on this and then see where the IOL has to go.
All right. So we really, like, the audience is really split on this. So what I'm doing is I sort of have it. I reach for the viscoelastic in the other hand. I don't want to let go. We got that giant opening, and with a dispersive, it kind of stays where you put it. And look at where I have the irrigation. I'm just trying to keep the chamber formed. I like Vladimir's idea, though, of a dry aspiration. I could have done that, so I don't wash it away. But I'm not sure what lens to put in, but kind of I like Doug's thinking is, if I don't need to just yet commit to a monofocal in the sulcus, I'm not going to. So we got that out. So let's review now. We got an intact rhexis. Half the posterior capsule is gone, so we can't convert that to a posterior rhexis. So question 3.4. So now we got the problem is, this is a young woman expecting the trifocal lens. And so let's go to the options. Would you put in a three-piece monofocal in the sulcus? Would you do the trifocal with reverse optic capture or an EDOF lens or something else? Remember, she wants to maximize spectacle independence. She's been used to many monovisions, so we got a lot of choices, so please vote now. So show of hands from the audience. How many people would put a three-piece monofocal in the sulcus, right? No reason to turn this into any more of an adventure. And how many of you who voted that would make her a little myopic? Yeah, because she was monovision before, right? All right. How many people would put the trifocal that she's already paid for and reverse optic capture? Remember, it's a toric trifocal. Okay. How about a toric EDOF? How about a non-toric EDOF? Okay. How about Doug, would you put a light adjustable lens here in the sulcus?
I think a light adjustable would be great. I think a monofocal in the sulcus would be great. You mentioned that she didn't like her monovision all that much, but remember, she's been looking through a posterior polar cataract all the time, and that really impairs near vision. Her near vision is going to be a heck of a lot better with a monofocal now that you've not only taken out the posterior polar, but half of her vitreous.
No floaters.
No floaters. Yeah, no, seriously, right?
Yeah. Vladimir?
Maybe monofocal optic capture, and then later on add-on multifocal.
An add-on. I like that. Okay. Foss, so in the United States, we have the light adjustable lens. What would you do here? We really did talk about this a lot. She really liked the idea of the trifocal.
So I would do the three-piece in the sulcus with optic capture, but leaving her a little myopic, because I think because she's been wearing her monovision soft contact, I think she would be happy with that. You could consider, the trifocal as well, because your capsulorhexis is this, the anterior capsulorhexis is perfect.
Namrata?
So I think, David, you would have already counseled her beforehand that you've got a posterior polar and I may not be able to put a panoptics. So I think then that case, you would also be ready with a monofocal lens and make her slightly myopic and then again counsel her back.
So that's a really key point that Namrata picked up on, right? A posterior polar cataract with a premium lens, you're going to explain there's different options. One of the problems, we have the light adjustable lens in the United States, but if you don't have that preoperative opportunity to talk about it, it's much more expensive. You have to wear UV glasses. You have to come back for adjustments. Very hard to switch places. But we actually did talk about that with the posterior polar. All right. So this is a challenge because these patients get wedded to the idea of the lens, and I'm pretty aggressive because I'm thinking even if it doesn't center well or the power's off, we can always go back and put in any of these choices. But she's really only got one shot at the trifocal, and I think this is where you have to know your patient. I wouldn't recommend this for everyone, but I think since I have an intact rhexis, I'm going to give it a try. And if it doesn't work, I can go back and do a light adjustable lens or so forth. So who wants to walk through how to do reverse optic capture? Tetsuro.
I completely agree. I tried to panoptics with the reverse optic capture, but it doesn't succeed 100%. In some cases, it is not. It may fail. So in that case, I exchange to another option during the surgery.
Okay, great. So this is reverse optic capture. So just to review, the optic will remain anterior to the rhexis, and the haptics will be underneath the anterior capsule. So because there is no posterior capsule, I didn't want to put the whole lens in the bag and have it drop because I've done a vitrectomy. So I have to put the lens in the sulcus, and that means one haptic at a time I have to sort of get underneath the rhexis. So it's easy to do the first one. You can see here's the toric. Remember, she has that against the rule. And it's the second haptic that's harder to get underneath. And so the idea is you're capturing the optic from above rather than below. And when you do this, you'll end up with almost a rectangular shape to the capsular opening, as you see here, because of the wide base of the optic-haptic junction. And so right there, and remember, it's about a 165 axis. So, and it centers pretty well. So it's very important to have the rhexis centered. And again, at this point, we don't know on the table how well it's going to do, but I can always go back and swap it, or she can have a keratorefractive touch-up. Yeah. Comments about reverse optic capture? I mean, experience with it, does it work? Foss?
I was just going to ask David, so we don't have the three-piece version. Well, we used to have like three-piece diffractive lenses, but a three-piece trifocal would be nice. Is that something that we might see in the future?
Yeah, I think, I don't even know if a three-piece restore is even currently available. I doubt it. But that, you know, there was a time. I agree, yeah. Comments?
Another consideration, you mentioned LAL. The LAL Plus is another option for this lady where you'd make her like -75 and she'd have good range of vision. And that, of course, you could do a posterior optic capture. But
Yeah.
what you did was very slick.
So and I think the point is, I think all of these are really good options, defensible. You just sort of have to think about what would I as a patient want. And I think it's viable to try it knowing that you're not stuck. You know, we had, fortunately, the benefit of saying that, you know, the posterior capsule is probably abnormal. Yeah. Any other final thoughts on reverse optic capture?
Yes, one point about reverse optic capture. Doing that with a single hand is very difficult. You did a very good way, you know, very sophisticated, but I recommend to use a bimanual technique, both hands, by using maybe MST forceps to hold the optics, and using the right-hand side to manipulate haptics. Or such kind of bimanual technique really works for reverse optic capture.
Yeah,
So, David,
particularly for this technique, where there's two ways to do it. One, you put the lens in the bag and pop the optic up, but I like that because here, like I said, I've done a vitrectomy, the posterior capsule's half gone, and I don't want it to flip back. Yeah, Namrata?
So, David, I just wanted to ask you, how many, what would be your experience? How many you would have done reverse capture?
Yeah, a total number of cases?
Yeah,
A dozen.
okay.
Yeah. How many in the audience have done reverse optic capture? Yeah, so it's a fairly high number. It's a pretty powerful technique, and of course, you know, the question is, aren't we not supposed to put a single piece of acrylic in the sulcus? And you're not, because you don't have the mobility that you do when the entire lens is in the sulcus. You don't have the sharp edges of the haptic exposed because they're tied up against the undersurface of the anterior capsule. And I think the key is because you have those haptics tucked in, it really pulls the optic down to the level of the rexus. So I'm not aware of, you know, this is all anecdotal, people reporting UGG syndrome with that. Yeah. Experience in the panel, Vladimir?
David, great surgery. How did you adjust the optic power for the new effective lens position?
So it's a really good question. So there's a big study by Tom Oding and Jason Jones, which had, I believe, 26 eyes or something like that. And they found that there was a mean myopic shift of 0.36. So what it basically means is, you know, you're obviously moving the optic forward. That should create a myopic shift. And so the answer is, if it's a lower power lens, I would leave it alone. And if it's a higher power lens, you know, say more than 20, I would cut a half diopter. Yeah. So in her case, it was a lower power, we left it alone. All right, so yeah, it was a 17. So I actually didn't change the power for that reason. Wow. So this was, I was lucky here. And there was certainly cortex in the vitreous. We left that there. It eventually reabsorbed. And she really liked the PanOptics, so she actually chose it for the other eye, and now she has that bilaterally. So, you know, but it easily could have ended up the other way, and I'd be going back and putting in an LAL or something else like that. So good discussion, panel. All right, we're going to move to the next case, and yeah, I have 2-year follow-up. All right, so here's well, finally, this patient's already had a vitrectomy, so, but she had a rapid onset of her cataract, and I'm seeing her 8 weeks, and she already is having trouble seeing. You can see the PSC. She had an epiretinal membrane at age 58, and she's already down to 2200. Now, she cannot wear contact lenses, And when you kind of adjust the illumination, you kind of see this strange looking, well, we know what that is, right? That's a little bite out of the posterior capsule from the vitrector. All right, so audience, let's show question 4.1. So there's a possible PC defect, obviously. Do you go ahead and do your normal hydro steps? Do you hydro delineate only? Do you forget what you're not supposed to do, so let's just skip all the steps, or do you refer the patient? So please vote now. How many people would just normally hydrodissect, hydrodelineate? And how many would hydrodelineate only? So like a posterior polar. How many would just skip them all? Yeah, okay. And then how many would just not do this patient? Yeah. So really, this the audience is all unanimous on the hydrodelineate only. What do you think, panel? You agree with the audience?
My concern about doing any kind of injection into that lens is that the tear could extend. So my approach would be to sculpt it, break it into 2 pieces, and then viscodissect each half into the anterior chamber with a dispersive so that I'm not, and I have that dispersive behind preventing it, hopefully, from falling back.
So I just want to know what is the duration between the injection and the presentation?
This was not an injection. She actually had a vitrectomy, and it was, this picture is 8 weeks out.
The duration between vitrectomy?
8 weeks ago. Yeah.
So because that will also determine the edges of the posterior capsular tear, whether they will be fibrosed or they will not be fibrosed, because if it's a pre-existing one, then it may not enlarge when you do the case. But if it's an intraoperative one, then it tends to enlarge.
Yeah, that's a good point. This one is fresh. That's why the cataracts come on quickly. And but that would be nice if it was fibrotic. Yeah,
yeah, 8 weeks is not enough to be, have some calcification occur around in the circle. So I avoid any hydro procedures. And I do phaco, and it's 58 years old. It's easy to remove the nucleus part. Right. After that, I do hydrodelineation.
Okay, all right. So let's show both screens now. All right, so here I am, and of course, the rexus, we didn't, talk about that, but we got to make it for sure. So this was what Doug was talking about earlier, and it's not really visco dissecting into around the edge. It's really just separating from the anterior capsule and into the fornix, and you don't want to overinflate the eye, so you got to make sure that you keep burping it out so the eye is soft. And then I just want to chop this in half. I think the one thing I have to avoid is not rotating the lens, because when you rotate it, you're really pressing against the capsule, and that's when I think you get into trouble with tearing. So luckily it's soft, and that visco separation really doesn't go posteriorly, although I am trying to sort of claw away from that. And I'm basically trying to aspirate at this point. As one of the panelists said, there's not a whole lot of nucleus there. You got to turn the port backward. And now how am I going to get the rest of that? Okay, well, that's coming out. All right. So, well, I did the easy part. Now look what's left. Question 4.2 for the audience. How are you going to handle this adherent epinucleus? So let's show the choices, Karen. You want to either aspirate it with a phaco tip. You show 4.2 the choices, please. Do you pause to either hydro or visco dissect, or just switch to INA at this point? So please vote now. So how many people would continue aspirating with a phaco tip? Raise your hand. So, yeah, we're making progress. How many would hydrodissect now? Probably not going to blow it out at this point, right? How many people would visco dissect now? Okay, a lot of movement on that. And how many would just switch to INA without anything else? All right, so I think most people. Foss?
Yeah, so at this point, you have this adherent epinuclear shell, so I think visco dissection is a good option. I mean, the patient's fully vitrectomized, so you're not worried about vitreous loss. What we're trying to avoid is having any pieces go through that small opening, which does look fibrotic, as you mentioned. So I think viscodissect, and then you could either go in with the IA or phaco.
All right, okay. So, all right, so I'm kind of looking at things here, and maybe I shouldn't have come out so quickly, but it did actually let that thing rise up a little bit when the chamber shallowed, so that was unintentional. But now that it's up, I'm going to sort of go around there, try to free that up. All right, so panel?
So I would, again, dry aspirate and even maybe push viscoelastic in and push down on the incision so that this material would flow out of the eye through the incision.
Okay, so you'd almost visco-express the epinucleus, okay? All right. The choices were coaxial, biaxial. Well, let's actually, yeah, sorry. For the audience 4.3, we got some choices here. So we've loosened it up. Let's show the choices. You can either go after with a phaco tip, Karen, coaxial or biaxial INA, or the vitrectomy cutter. I didn't list Vladimir's dry, but please vote. All right. So how many people would get this out with the phaco tip? And how many would do coaxial INA? And how many biaxial INA? All right, that's a top seller so far. How many would just use the vitrectomy cutter? Few people would do that, all right. What about these choices? So most of the audience would do biaxial INA. Namrata?
Biaxial INA, because it's already post-vitrectomized eye.
Okay, all right. Tetsuro?
Phaco.
You would go with a phaco?
Phaco, yes, simply.
As a man in a rush, man in a hurry.
And I think the biaxial versus the coaxial, I mean, your biaxial will give you a little more versatility, and like you said, you can use the irrigation and strategically place it to prevent the pieces from falling back.
Yep, so dissociating INA. Yep, Vladimir likes the dry and the visco expression.
Yes.
Yep.
You can inject viscoelastic at the same time as you aspirate, so bimanually. No
so
problem.
you're using your left hand, or one hand with, and what viscoelastic do you use?
In this case, always methyl cellulose, because you can aspirate it easy.
Okay, great. Yep. Doug?
Yeah, I would be very comfortable with biaxial here. I think that'll work well. But you have to control where you're directing your irrigation. And if you don't want to, you want to irrigate beneath that material, so you're floating it up. You don't want to irrigate in front of it because you don't want to push it back. So you can use the biaxial component to help.
All right, great. Oh, looks like I went with the coaxial, and I'm using, and I think the reason I'm doing that is I kind of know this is epinucleus, and I wanted my left hand to be sort of a masher. So I like your thinking, Fasika, that you can dissociate INA, but this is all epinucleus. That's why Tetsuro wanted to do it with a phaco tip, and I just kind of like using my left hand now to sort of help push that through. And okay, that's looking clear. Looking really clear. I think it's definitely way too clear there. Let's go to the audience, and we got question 4.4. Yeah, so we got a large PC rent audience. So your choices are, let's just keep going, or are you going to do the anterior vitrectomy? If so, are you going to go through the limbus or the pars plana? Or would you just leave the epinucleus here? We've kind of done enough. And, the vitreoretinal person kind of caused this problem in the first place. It's time to send them back to the vitreoretinal surgeon. All right, so how many people would do number one, the red choice? Continue INA. I see almost nobody. How many people would do an anterior vitrectomy but do it through the limbus? So lots of hands up there. How many people do the pars plana anterior vitrectomy? Very few, okay. And how many people would send it back to the referring retina specialist? Okay, I would be surprised. So clearly anterior vitrectomy through the limbus. All right. Let me ask Namrata.
So I would do anterior vitrectomy from the limbus, and then again, like I said earlier, use that same vitrectomy probe to do IA, and then put the intraocular lens.
All right.
David, are you assuming there's some vitreous left because this patient was fully vitrectomized, right? So that's why I wouldn't be as concerned as dealing with the vitreous, assuming there's nothing left behind.
So that's exactly, this is a trick question. That's right. I'm saying, I'm going to trust they did such a good vitrectomy, they took part of the lens capsule. And so I'm just going to keep going because, look, if it drops down, it's sort of a shared responsibility here. And this is, fortunately, you see how that lens posterior capsule is quivering, and then I can even see the viscoelastic that I put in is like coming back up from the vitreous cavity. We don't need to take that out. So just to be sure, I'm going to kind of protect as I come out. And let's see what we got. So the rent did expand in one direction, but it didn't go all the way to Argentina on the other side. So we've got a, got a partial. So we actually have a little bit of a bag there, and we've got a rhexis, okay? So this is one of the few times when you don't need to do the vitrectomy, potentially, because of the fact that they did an epiretinal membrane peel. All right. So we've got a large rent, and we've got to decide on the lens. So we've got a bag. Now, this is a young patient, and she did actually kind of like the idea of one of these lenses so that she see well without glasses. So, but she had an epiretinal membrane peel. So what lens would you have recommended, and would you put that lens in now? Tetsuro?
What was the original plan? What you prepared?
Yeah, we only have her vision, which was 2200 because of the cataract. So we don't know, and I don't really know how bad the epiretinal membrane was because I'm just seeing her after. She wasn't my patient, but she is young.
Yeah, probably.
Would you do an EDOF?
EDOF can be okay, and put in the capsule bag.
Yeah, you go in the capsule bag, right?
Yeah.
Because we did manage with all of the things we said, right? Not rotating and visco-dissecting, not hydrodissecting. That thing really didn't split all the way across, and we have a rhexis. Any other thoughts? Anyone want to do a EDOF with a reverse optic capture? Oh, okay. So go ahead.
Well, I think in this case, because the rent isn't as big as the last case, so I'd be less worried about it dropping, so you probably could do it in the bag.
All right, okay.
You could do in the bag also, but just put the haptics in the direction that the haptics they are perpendicular to the area of the tear.
Got it. Yeah.
And I would also say it depends on the EDOF you're going to use in terms of the platform, because the Alcon lenses are very easy and gentle to put, example, in the bag, and some of the other lenses are more stiff, and there might be a little bit more prone to put stress as you're putting the lens in.
Great.
I would also put it into the bag, EDOF.
And EDOF, okay, excellent.
And then in terms of the lens choice, I think that depends on your pre-op discussion in terms of what the patient would be willing to tolerate. With the ERM, not a great candidate, but if she's going to accept the risk, then you could try.
So this is a little bit of a trick question because you go into this case, the posterior capsule is going to tear, and given that and the fact that she had this macular pucker and we're not sure how much metamorphopsia, I kind of talked her out of anything but a monofocal. But it was good to get your thoughts on if she had wanted something like that. But in this particular case, I am going to put in a 3-piece in the sulcus. Any comments on just how to do that? Namrata, do you want to just comment on lens in the sulcus, optic capture.
She's on the phone right
Oh,
now.
sorry.
Running a meeting.
Doug?
You just want to put your OVD or your viscoelastic in the sulcus, and then do just as she suggested. It's nice to have the haptic sort of away from that posterior tear. It doesn't really matter though. But just in the case it would go around and get the anterior capsule. But it's pretty straightforward.
All righty, so there you can see the rent. So I think some of the pearls here, which really the panel helped me out on, is, what did we say? Don't hydrodissect, treat it like a posterior polar cataract, don't rotate the nucleus, try to chop it as much as we can, and don't worry about vitreous, but we did end up without dropping anything down there, and we made it through there. We have covered 4 cases, and it is exactly 2:45. So thank you very much to both panels. Thank you to the audience for joining this afternoon. Panels did a great job. Let's hear it for them. And thank you to the AV crew for all your help on this complicated session. We got another panel.
Oh, yeah.
We got another panel. Charles, hey, Hatem, how are you?